Welcome to this follow-on lecture from the Dermatomes and Myotomes lecture. For those who did not get to see that, I'm Richard, plastic surgeon at North College University Hospital and head of anatomy here at UEA, and Charlie is our talented artist and lecturer in anatomy also at UEA. I'm sure you'll be able to tell which are his illustrations rather than my poor attempts. This is the question I put at the end of the last lecture. As I'm sure many of you have heard me say, we're teaching to be doctors, not anatomists. Hence, UEA appointed a clinician such as me as head of anatomy. We want to be able to establish a site of a disease process in order to help diagnose the cause of that disease process and hence, ideally, be able to correct that disease process. Hopefully some of you heard my 3 rules of medicine in the past. This is all we do in medicine and can be applied to all aspects of medicine. We establish the diagnosis by taking history, examining the patient, and maybe doing some investigations. We do the same to establish the extent of disease. Doing these 2 establishes the management plan. It really is this simple. But don't tell anybody else this. So let's briefly recap the summary slide from my previous talk and Sue's talk on peripheral nerves. Remember, dermatomes and myotomes relate to a single nerve root and their distribution. The spinal nerve roots join together in the brachial plexus and lumbar plexuses to form the peripheral nerves that go on to innervate the skin and muscles of the limbs. Try and remember the patterns of dermatomes and the patterns of myotomes and the individual patterns of peripheral nerves. Firstly, let us simplify the innervation of tissue, and Charlie has kindly given us some abstract diagrams. Here we have 2 spinal nerve roots, D1 and D2 on the left, and a block of tissue on the right. Spinal nerve root D1 innervates the left portion of the block of tissue. Spinal nerve root D2 innervates the right portion of the block of tissue. The individual nerve fibres connecting D1 and D2 and the block of tissue are bundled together in peripheral nerves PNX and PNY. It is more complex than this in the human, but hopefully you can remember how the upper limb nerves are made up of nerve fibres from C5 to T1 nerve roots bundled together by the brachial plexus. Certainly when I was a medical student, the thought of the brachial plexus would make me break out in a cold sweat. So let's keep it simple again. You can see that the upper half of the block of tissue is innervated by one peripheral nerve, PNX, and the lower half of the block of tissue is innervated by a different peripheral nerve, PNY. So now look carefully at the innervation of the block of tissue as a whole. The upper half receiving innervation from both D1 and D2 via peripheral nerve PNX, and the lower half receiving innervation from D1 and D2 via the peripheral nerve PNY. Conversely, the left side of the block of tissue receives its innervation from only D1 via both peripheral nerves PNX and PNY. The right side of the block of tissue receives its innervation from only D2 via both peripheral nerves. You will see if a disease process is affecting different parts of this innervation pathways, there will be different losses of innervation. Let us now look at those potential patterns. If there was a disease process in nerve root D1 and the nerve fibres in D1 were not working, the sensation in the skin and muscle function within the left half of the block of tissue would not be present when being tested for. If in D2, the right side would be affected. If in peripheral nerve PNX, the upper half of the block of tissue would lose sensation and motor function. The last pattern of loss of function is if the peripheral nerve PNY is affected. Then the lower half of the block of tissue will lose sensation and motor function. So Charlie has elegantly illustrated the pattern of loss of function caused by a pathological process is dependent upon the position of that pathological process. As you have been taught by the UEA anatomy team, your knowledge of the normal anatomy is obviously excellent, and you can use that knowledge in reverse to work out where a disease process is occurring, investigate it appropriately, make a diagnosis, and treat your patient. Let's have a go. You'll hear my secretary working in the background, but she's trying to be a church mouse. So our first case is Cecilia, a 48-year-old office worker who presents to your clinic concerned about her shoulder and arm. She has some aching and pain in the shoulder and axilla, slowly increasing to a severe burning toothache, now going down her arm. On examination, she's got some neck stiffness and tenderness, reduced sensation over the lateral forearm, radial side of the thumb, and index finger. She had reduced power of shoulder abduction, shoulder extension, forearm supination, wrist extension and flexion. So, some reverse anatomy. Does the pattern of sensation loss fit a dermatome distribution or peripheral nerve distribution? Remember the 6-shooter tip for remembering dermatomes? So sensation loss fits C6. Now looking at the myotomes, she has reduced shoulder extension, elbow flexion, and elbow extension. Wrist flexion and extension and supination are reduced, but other movements are normal. The common myotome for the reduced movements is C6. So our working diagnosis is a C6 nerve root problem. You go on and request an MRI of the cervical spine on ice. With the clinical information you give the radiologist on the request form, they quickly identify a prolapsed C5-C6 cervical disc pressing upon C6 spinal nerve root. With this information, you request a physiotherapist input with careful mobilization, postural exercises, and monitor and keyboard positioning advice. 8 weeks later, you receive a perfectly formatted letter of thanks with an attached Excel spreadsheet of a range of movements. You think you may address Cecilia's OCD a bit later on. Our second case is Carl, who sits next to Cecilia. So does this pattern fit any specific dermatome or myotome? Or does it cross dermatomes and myotomes? The thumb and index finger are C6 dermatome, but the middle and ring fingers are C7 dermatomes. It is also only the volar sensation loss, and C6 and C7 covers the dorsal surface too. Strange. Abductor pollicis brevis is one of the intrinsic muscles of the hand, and these are within the T1 myotome. A nerve root problem affecting 3 separate, non-adjacent nerve roots would be extremely unlikely. So we need to look at a different part of the nerve pathway where various nerve fibres from different nerve root origins are bundled together. I hear you shout, there is a Tinel sign at the wrist indicating damage to the nerve fibres there. Being the switched on UEA graduates that you are, you request nerve conduction studies, giving the salient clinical information on the request form. The neurophysiologist's reports show slowing of the median nerve at the wrist, indicating demyelination within the carpal tunnel. Having had an unforgettable upper limb surface anatomy tutorial, you are able to remember the surface anatomy of the flexor retinaculum, and under local anaesthetic you can release Carl's carpal tunnel. A few months later you receive a beautifully formatted letter and several Excel spreadsheets and graphs from Cecilia charting Carl's recovery. Where are those OCD clinic forms gone? Our third case is Branson, a 32-year-old plasterer. He'd been getting a worsening aching pain in his forearm and hand, particularly when working on ceilings. He had also noticed he could not hold his tools as tightly as he used to. His last job had been particularly bad. It was the ceiling and an extension. It had taken ages to do, as the slightly unusual client wanted circular and square patterns moulded into the plaster. She recommended he see yourself though, as you had studied at UEA. On examining Branson, he had loss of bulk of the thenar and hypothenar eminences and guttering between the metacarpals. He had reduced sensation in the inside of the arm, forearm and little finger. His power of pronation, finger abduction, finger adduction and thumb opposition was all reduced. So this one is a bit of a head scratcher. Reduced sensation in 2 dermatomes, C8 and T1, but 3 different nerves. The ulnar nerve, the medial cutaneous nerve of the arm and forearm. Also, there is reduced power covering 2 myotomes, C8 and T1, but 2 nerves, both median and ulnar. Can you remember an area in the body where nerve roots are bundled together? Ah, there's that breakout session from the dissection room with those wire models. Aha, the brachial plexus, I hear you shout. The inferior trunk is formed by the fusion of C8 and T1 nerve roots. Let us request a plain X-ray looking for cervical ribs and discuss with the radiologist to see if they want to do a CT or MRI to see if Branson has a cause for thoracic outlet syndrome and compression of the inferior trunk of the brachial plexus. After referral to the thoracic surgeons and a successful decompression, you receive another beautifully formatted letter from Cecilia with Branson's recovery illustrated in pie charts and graphs, this time painted on the embossed walls and ceilings of her new extension. I must get round to doing that referral to the OCD clinic, you think. So hopefully you can see your anatomical knowledge allows you to be a nervous detective, delving about within nerve roots, plexuses and peripheral nerves to identify and stop those criminal disease processes. I hope it's been a useful session. Keep safe and keep looking out for each other.